Hello, and welcome to this latest episode on HIV by Medthority. In this series, our hosts are Dr. Margherita Bracchi and Dr. Borja Mora Peris, who will be discussing antiretroviral treatments for managing HIV infection. All opinions expressed in this podcast are those of Dr. Margherita Bracchi and Dr. Borja Mora Peris. Over to you.
Hi, welcome to this HIV Podcast Series. We are going to talk in this first episode about antiretroviral treatments for managing HIV infection. My name is Dr. Borja Mora Peris, and I work as a consultant in sexual health and HIV at Imperial College Healthcare NHS Trust in London.
And hello, my name is Margherita Bracchi, and I'm an infectious disease consultant working in the HIV genitourinary medicine department at Chelsea and Westminster Hospital.
So first, Maggie, can I ask you, what are the recommended antiretroviral regimens for treating HIV infection, and how do we use them in special patient groups?
So currently, most guidelines, international guidelines, would recommend a combination of two NRTIs, so nucleoside retrotranscriptase inhibitors, plus a third agent, which generally is a second-generation integrase inhibitor. Also, we have the possibility of the use of a second-generation integrase inhibitor, dolutegravir, in combination with a single nucleoside retrotranscriptase inhibitor called lamivudine, and that is a dual therapy for patients either starting or switching antiretroviral treatment. We of course have got alternative regimens as well, and that can be used in a special population, like the use of non-nucleoside retrotranscriptase inhibitors as third agents, as well as boosted protease inhibitors.
That sounds fantastic. That sounds like a big array of drugs that we have to actually treat our patients in a personalized manner. What about, just because I've got several questions recently in the clinic about injectables, could we start patients on injectables? So what's the use of injectables these days?
So that's a very interesting question and a very topical one. As you said, many patients are asking about injectables as they offer an alternative to oral treatment. And the licensed injectables that we have are a combination of rilpivirine and cabotegravir, which are long-acting agents, and they've been licensed now for use only in people that are already undetectable, so are established on antiretroviral treatment. They have definitely some advantages in regards to reducing the pill fatigue and the need for taking medication every day, but they do have some pitfalls. And actually, Borja, can you tell me what the pitfalls are?
Well, in terms of like when we discuss these patients in the clinic, we all get together in the MDT and think about whether those will be appropriate. We think about whether the patient is going to be able to attend the repeat dosing every 2 months. That's a problem that we have because in the studies we have seen that despite actually attending on time, some patients develop resistance. And when they develop resistance and the virus starts replicating again, that's what we call virological failure, that virus also develops resistance for both agents. And that's a very tricky situation since these two agents that we are using, cabotegravir and rilpivirine, that you mentioned before, are members of families that we use for triple therapy as well. And those families will be written off potential future combinations. So it's something that we have to really think about. We have actually looked into why is that some patients actually experience this virological failure, even though they attend on time and they get the injections on time. And we have identified several problems. One of them, for example, not being able to acknowledge that the virus wasn't resistant to any antiretrovirals in the first place when we started this treatment. Another one is that the patients might have had a BMI over 30. And another one is that the clade of the HIV virus will be A1 or A6. And that's something that, we have to look into when we decide whether we will recommend those treatments to patients. Having said so, I think that there is a huge field nowadays to stop being paternalistic in our care and allow the patients to identify that there is risks together, coming together with the use of these injectables, and that if they understand and take on that risk, so they could actually try to use these antiretrovirals. It's just a matter of explaining the facts and patients being on board and personalize the care with the patient decision making.
Yeah, definitely. I completely agree with your points, and it's unfortunately it's not a treatment that would be available for all patients. Sometimes we have highly treatment experienced patients that definitely have been living with HIV for a long time and been exposed to older antiretroviral medication that wouldn't be eligible for this treatment, for instance, because of accumulated previous resistance. But nonetheless, it's a breath of fresh air for offering potential alternatives to oral tablets.
I completely agree. Particularly, we have some patients who really get reminded every day by taking the tablets about their HIV status, and that has caused them to suffer because of stigma. And in several situations, we have decided to just try to actually go ahead hand in hand with the patient to move along these routes, and that has made a massive difference in their quality of life. Maggie, let me ask you about how quick would you start treatment on patients when you see them in clinic and you have just diagnosed them? Would you push them? Would you just wait for some results? What do you think about that? What's your normal clinical practice?
So I think it's a very important question that luckily we've had now a lot of data from clinical trials, both observational and randomized clinical trials that have given us a very important knowledge of how fundamental it is to start antiretroviral treatment as soon as possible. And this is both to reduce HIV kind of related morbidity and mortality, but also to reduce what we call non-AIDS related events. So what we know in the clinical setting as anything that would be related with a state of inflammation produced by ongoing HIV replication. We know that, for instance, an uncontrolled HIV infection can lead to toxicity in terms of cardiovascular disease, renal disease, liver disease, and neurocognitive impairment, and so on. So more and more there is a push to start as soon as possible, and in some settings even on the same day of diagnosis, which has been linked to a increased linkage to care and to antiretroviral treatment. However, also starting on the same day, for instance, would have some problems. We wouldn't have all the information needed to potentially choose between the antiretroviral treatments. So we would need to start with medication that would have a high barrier to resistance, as we won't have a baseline resistance test on this patient, and also medication that would cover for hepatitis B infection, as we would be lacking information in regards to, for instance, co-infection. So those are important points. And whilst we used to give a lot of importance to making sure that patients were ready to start antiretroviral treatment, I think we're shifting now to start as soon as possible. And we've got the luxury of very quick turnaround of tests as well here.
That is very, very insightful. One thing that I always think is that since more or less, I think it was mid-2015, we had the evidence that, and you mentioned from the START trial that starting treatment as soon as you are diagnosed will be beneficial for the patient. But we do know that for some years before, if you start treatment and reduce the viral load, you will actually stop transmission of the virus. And that's something that has been one of the main kind of cornerstones of starting early antiretroviral treatment, particularly, we would say, in vulnerable or special populations. I am thinking about patients who might have a very active sexual life or might have other transitional kind of challenges, such as adolescence. So those are patients that we sometimes think about as established on treatment, but when they actually move from the pediatric care to the adult care, sometimes they suffer from poor adherence and the virus gets uncontrolled. Have you experienced, and can you explain to me what you have seen in clinic in terms of pitfalls that you might have with those patients? Anything that you would recommend around their care?
Thank you for this question. I think it's extremely challenging to look after adolescents living with HIV, and it is for a variety of reasons that you mentioned. First of all, they might have struggled along their childhood, with having to take medication every day. And so we often see that actually when they transition to adolescence, they would rebel and stop their antiretroviral treatment. And perhaps they've been exposed to older antiretroviral regimens that had given them a lot of toxicity side effects. And so they decided to kind of stop treatment because of not wanting to experience those side effects. So there is a lot of resistance in terms of potentially starting something new, and the challenges are to select a regimen that would be of efficacy in patients that might have selected a lot of resistance. So this is challenging as well, because we might not be able to construct a regimen that is with a low number of pills and free of side effects. And what we have seen that is of extreme importance is to try to get any support from the community, so community nursing and continuity of care in terms of their clinician to really listen to the needs of this growing.
So I really am taking on board that you do have actually deliver a package of care when you are trying to treat these patients, and that there is a lot of things actually that we can actually do to improve their care. But in the sense of basic science, and therefore for example, other options in terms of investigational antiretrovirals, new drugs that are in the pipeline, new deliveries, new ways of approaching patients with difficulty to adhere to treatment, or patients who have multi-drug resistant virus. What would you be actually hoping for in the coming years?
I think we have to keep our eyes open to what's been in the development. So we do have a few novel agents that are now under studies and are in general looking at alternative ways of administering antiretrovirals, a bit like the long-acting injectables that we've discussed before, so other long-acting antiretrovirals, as well as IV infusion that can be given every couple of weeks or so. And novel antiretrovirals given as oral treatments that have got different or novel ways of activity over the virus, and could be salvage therapy in people that have got very limited active medication. I think what's really going to be a game changer might be the possibility of implants, where there is less need for ongoing administration of medication. But that has also some potential problems when it comes to onset of toxicity, because you would not be able to remove the implants so easily.
So yeah, it sounds like there is just not one size for everyone, but that actually we will be able to make different sizes for each patient, so we actually can cover their needs, individual ones. So it sounds like a very promising field, and it's something that we will look into probably in the coming 2 to 3 years. Thank you very much. So
please follow us on the next episode, where we will discuss main side effects and challenges of antiretroviral treatment.
We'd like to thank the faculty involved in this production. Don't forget to stay tuned for the next episode. Meanwhile, you can explore more HIV content online on the Medthority HIV Learning Zone. Simply register and log in at www.medthority.com. Thanks for listening.